All right, let's dive straight in. Welcome to today's explainer, where we're unpacking a medical procedure that is incredibly common, yet carries literally life or death stakes. We're talking about the nasogastric tube, a simple plastic device that basically bridges the gap between the outside world and the human stomach.
It's a total paradox, right? I mean, in the US alone, over 1.2 million of these temporary NG feeding tubes are inserted every single year. But here's the catch. Because the clinician inserts this tube entirely blind, improper placement without rigorous verification can lead to catastrophic and honestly, sometimes fatal harm. So today, we're going to uncover exactly how this procedure works and the meticulous science used to keep patients safe.
So, here's our clinical pre-flight checklist for today. First, the NG tube explained. 2. Anatomy and contraindications. 3. The insertion procedure. 4. Verifying safe placement. And finally, 5. Complications and care.
All right, starting with Section 1, the NG tube explained. Now, this isn't some brand new piece of tech. Its use was actually first described by Dr. Abraham Levin over a century ago, way back in 1921. And despite being over 100 years old, this device basically serves two massive, life-saving missions. The first is stomach decompression. So imagine a patient with a bowel obstruction, or an ileus, right? Their intestinal contents are physically blocked. The NG tube acts like this vital pressure release valve, pumping out all those built-up fluids and gas to stop severe pain, nausea, and the really dangerous aspiration of stomach contents into the lungs. Now, the second mission is the exact opposite. It's delivery. For patients who can't safely swallow, say after having a stroke, the tube becomes an absolute lifeline for delivering critical nutrition and medications directly into their GI tract. And you know, the physical design of the tube totally dictates its function. You've got your fine-bore, flexible polyurethane tubes for enteral feeding, like the Dobhoff or Levin tubes. They're soft, small-bore, usually about 8 to 12 French, mostly to maximize patient comfort. But that's completely different from the tubes used for decompression, like the Salem sump. Those are rigid, they have a wider bore, and they feature a double lumen design so they can safely suction the stomach without damaging the gastric lining.
Moving right along to Section 2, Anatomy and Contraindications. Now, keep in mind, the clinician is doing this procedure totally blind. They are relying purely on anatomical knowledge and technique.
And the anatomical pathway? It is incredibly unforgiving. The tube enters through the nares, goes straight back along the nasal floor, and drops down into the pharynx. From there, it has to navigate down a roughly 25-centimeter-long esophagus, push past the cardiac sphincter, and finally land safely in the stomach. The total journey for an adult is roughly 55 centimeters. But here's the thing. The most critical make-or-break juncture is where the respiratory and digestive systems split. Take one wrong turn, and that tube ends up in the trachea instead of the esophagus. But wait, the lungs aren't the only danger zone here. Right at the end of the nasal cavity is this very thin bone called the cribriform plate. It is a terrifying reality that if a patient has a fractured cribriform plate, attempting to blindly insert an NG tube could actually result in the tube passing directly into the brain.
Yeah, because of extreme risks like intracranial placement, assessing the patient before that tube ever even touches their nose is absolutely non-negotiable. There are strict, absolute contraindications where placing an NG tube could literally be fatal. We're talking severe facial trauma, basilar skull fractures, recent surgeries on the nose, throat, or esophagus, and esophageal obstructions. In these situations, blind insertion is totally off the table.
Okay, Section 3, the insertion procedure. Now that we've got a handle on the anatomy and the risks, let's head to the bedside and see how nurses and doctors actually pull this off safely.
So before they even start, clinicians use this brilliant little bedside trick called the neck measurement technique. They measure the tube from the tip of the patient's nose to their earlobe and then straight down to the xiphoid process, which is right below the sternum. Doing this gives them a highly accurate custom estimate of exactly how much tubing they need to hit the center of that specific patient's stomach.
Then, as the tube is gently advanced past the back of the throat, clinicians use a super fascinating bit of human physiology to help them out. They'll often ask an awake patient to tuck their chin down and take sips of water. Why do that? Well, swallowing activates the epiglottis. This little cartilaginous flap acts like a natural bouncer, snapping shut over the larynx to protect the airway, which forces the NG tube to bypass the lungs and slide right down the esophagus. Which brings us to Section 4, verifying safe placement. Just feeling the tube slide in smoothly? That is not enough. We've hit the most critical, high-stakes moment of this whole explainer, actually proving the tube is where it's supposed to be.
Now, listen, for decades, a lot of clinicians relied on this thing called the whoosh test. Basically, they'd inject a syringe of air into the tube and listen over the stomach with a stethoscope for a bubbling sound. We need to vigorously debunk this right here, right now. Modern research proves the whoosh test is insanely unreliable and genuinely dangerous. A misplaced tube sitting in the left main stem of the lung can sound exactly like a tube in the stomach. No joke. So today, medicine relies strictly on hard, evidence-based science.
So what do we do instead? The modern first-line bedside verification is pH testing. The nurse will draw back on a syringe to pull up a tiny amount of fluid from the tube. Then they test that fluid using CE-marked pH paper that is specifically designed for human gastric aspirate. To prove without a doubt that the tube is sitting in a pool of stomach acid and not inside the lungs, that pH absolutely must read 5.5 or lower. But what if you can't get any fluid? Or what if the pH comes back too high? Well, looking at this official NHS decision tree, you see exactly how rigorous the safety protocols are.
If the aspirate check fails, clinicians don't just guess, they escalate. Strict protocols demand a chest x-ray. It's the absolute gold standard for verification, giving you undeniable, real-time visual proof of the tube's exact location before a single drop of food or medicine is pushed through.
All right, finally, Section 5, Complications in Care. Look, once the placement is perfectly verified, the immediate danger might be over, but the actual care process is really just getting started.
Having a piece of plastic dwelling inside your nasal cavity and esophagus comes with ongoing risks. We're talking everything from minor discomforts like nosebleeds, epistaxis, and sinusitis to severe mucosal pressure injuries if the tube rubs against the nostril for too long. And of course, the big ones, the severe medical emergencies we talked about earlier, like esophageal perforation, or the catastrophic results of inadvertent tracheo placement, which can cause a pneumothorax or severe pneumonia.
Plus, a verified tube doesn't always just stay put. There is this constant threat of tube migration. Really simple everyday things like coughing, moving around in bed, or vomiting can actually dislodge the tube and pull it right up out of the stomach. That's exactly why organizations like the American Association of Critical Care Nurses say you must re-verify the tube's placement at least every 4 hours and absolutely before every single use. You have to maintain constant vigilance.
So that leaves us with this final thought. How do seemingly simple, everyday bedside tools rely on such unforgiving, rigorous safety protocols to protect human life? It really gives you a profound respect for standard nursing practices and all the meticulous science that's hidden just beneath the surface of routine medicine. Thank you so much for joining me for this explainer, and keep asking those great questions.